Happy New Year, everyone. I'm Yong-seok Cho, an oral surgeon in Korea. I'm happy to announce that I recently performed 5,000 sinus bone augmentation surgery since I started sinus surgery at 1996. Today, I prepared a special lecture to celebrate this. Please enjoy. We know that 80 to 90% of implant cases at posterior maxillary regions are candidates of sinus bone augmentation surgery. I have been placed more than 35,000 implants, and many of them are involved with sinus surgery. Today, I will present a lecture with the following topics. First, statistics and memories of my sinus bone augmentation surgery. Second, the milestone surgeries, my contribution to sinus bone augmentation surgery, the anniversary case of 5,000 maxillary sinus surgery, and the last, epilogue. First, statistics and memories of my sinus bone augmentation surgery. I started sinus surgery at 1996. Until last year, I experienced more than 3,000 lateral sinus surgery and 2,000 crestal sinus bone augmentation surgery. So total is more than 5,000. Statistics of sinus bone augmentation per year. Since 2009, I have been performed about 300 sinus bone augmentation surgery per year. And this is statistics of cumulative sinus bone augmentation surgeries. It took me 5 years to perform 100 sinus surgery. Next, it took me 6 years to perform 1,000 cases. After then, about 3 years to experience every 1,000 sinus bone augmentation cases. Okay, so it exceeds 5,000 recently. When I started implant and sinus surgery at 1996, sinus surgery was not popular. I was a beginner, and it was period of learning, and at that time, sinus surgery was an age of ignorance and fear. There are some notable events in the history of sinus bone augmentation surgery. The first dentist who performed sinus graft was Dr. Boyne at 1960s. In 1976, Tatum presented the technique of sinus bone augmentation surgery through crest or lateral. And 1980, Boyne published the sinus graft technique. 1994, Summers introduced the osteotome technique. In Korea, Dr. Kim Hong-gi first tried sinus graft. And here is very important meeting. It is a consensus conference on the sinus graft in Massachusetts Babson College. The maxillary sinus bone graft was approved as a highly predictable procedure at this conference. After this conference, sinus surgery became more popular. Okay. At that time, sinus bone augmentation surgery considered as very hard and risky surgery, which was performed using extraoral bone graft under general anesthesia. So it was very difficult to perform that surgery. It was performed only by oral surgeons in dental hospital or very brave private clinics. There are several pioneers, and I learned sinus surgery from them. At 2000, I met Kyok Che, the CEO of OSTEM Implant Company. This fateful encounter led me to take my first step as a lecturer. Okay, this is experience of 1,000 sinus bone augmentation surgery. It was a leap from intermediate to expert. It was a period of improvement and era of catacyclism. At that time, there was evolution of surgical techniques and comprehensive researches on materials. Okay. 2003, Lundgren published a very interesting article. This is starting of no bone graft in the sinus. 2005, I performed the first live sinus surgery during the OSTEM meeting. And after 2006, I proclaimed the year to overcome sinus surgery. Okay. At that time, many Korean speakers started a sinus training course. 2006, I first tried a sinus training course in Russia, in Taiwan, and India. I started sinus training course in the overseas. Okay. I experienced 3,000 sinus surgery at 2013, and it was an era of confidence, moment of leap, and era of controversy and competition. That time, the crystal approach sinus tools invented and introduced in the market. There are so many kinds, but here is a turning point. This is the OSTEM casket, which is fine sinus crystal sinus surgery tool. This made the this is a game changer. After this, a similar tool introduced in the market. During this period, not only in Korea, at many countries, I continued the sinus training course. So many countries. Almost 30 times per year, I visited a foreign country and trained the dentist. Okay. 2008, I introduced a CSI technique, another name, double needle irrigation technique. Okay, then recently I experienced 5,000 sinus surgery. Okay. After 2014, I completed my sinus surgery. It is completely optimized, standardized, and simplified. Okay. This is stabilization and era of total mastery. During this period, I continued offline sinus training course in Korea and overseas. 2016, I introduced the CSBA technique, and 2017, I proposed the new terminologies for sinus bone augmentation surgery. It is SBA, CSBA, LSBA, and CLSBA. 2016, we opened the DentalBean website. This is the online education site. Through this site, I started online lecture and continued offline lecture and webinar like this. Because of COVID-19, last year, I concentrated on online lectures. Now I can say that I'm teaching the most fine sinus surgery in the world. Okay. The milestone surgeries. Okay. I have been performed live surgery during OSTEM meeting or my implant training course or invitation live surgery. It was 190 times. Among these, 60%, 114 case was sinus surgery case. I have several milestone surgeries. The first is 2005 at OSTEM meeting. That time, I performed lateral sinus surgery in this patient who missed 16 and 17. At that conference, 2,700 dentists attended. Okay, for implant was the title of newspaper. And I performed live surgery during the meeting. It was the first live surgery in Korea. Okay, patient has 3 to 5 millimeter remaining bone height, and I planned lateral sinus bone augmentation surgery. Okay, I prepared the patient, and then it was routine lateral sinus surgery. Made incision, and then expose the bone. I'll speed up here. Expose the bone and design the window, scored bone window. Okay. With explanation, I continue the operation. Okay. Expose the membrane and then separate the membrane. After membrane separation, I prepared the implant sites. Okay. Routine preparation was done. And then here prepare the graft material. Okay. Harvest the maxillary tuberosity, and with the general graft, sinus graft was finished. Next, place the 2 internal gingival level implants. Okay. After implant installation, I finished the grafting and reposition the bone window. And it was a strong primary stability, so I can connect the healing abutments and then approximate the flap. Okay, like this. Okay, it was live surgery. I was a little bit nervous, in tension, but I can finish surgery successfully. It took me 27 minutes for this surgery, and 6 months later, bridge was delivered. Okay. This is 11 years follow-up. Look at the nice bone formation in the sinus. Okay, next was 2011 at Poland. Okay, Austin World meeting. And that time, I again performed the live surgery in front of a European dentist. Okay, and here is the Polish dentist, and his father was the patient. He missed multiple tooths on the maxilla, and this is the panoramic view of this patient. Patient has limited bone height on the maxilla and has some problem. Radicular cyst exists, and the residual cyst also exists. So I have to control everything before sinus surgery. My plan was first perform epicoectomy and cyst enucleation. Next, at the right side, I will perform crestal sinus bone augmentation surgery using the casket, and I will place 4 implants. Left side, I will try lateral sinus surgery using the lasket, and I plan the total 8 implants. So I prepared with my assistant and then started live surgery. Okay, there are 3 parts here. Okay, upper is epicoectomy and cyst enucleation. Left side, crestal sinus bone augmentation surgery using the casket. Left side, lateral sinus bone augmentation surgery using the lasket. Okay. During the meeting, I had 1 hour for live surgery. So to do everything, I must hurry up. Okay. Luckily, the surgery was gone smoothly without accident, so I can do everything. Okay. Left side, I'm doing crestal sinus surgery. Okay. I'm separating sinus membrane with the hydrolytic system. And right side, I open the lateral window, and then to place implant, I'm preparing implant site. Okay. After bone graft, I placed the implant, total 8 implant on right and left side. Okay. I hurried up, and then I can finish surgery in time. Okay. The full video is available in DentalBean, I think. Okay, this is POP CT view. As I planned, I can finish the surgery. I spent 50 minutes for this surgery. And then I presented the POP result in front of the dentist. The response was great. 2014, there was also a meeting, world meeting at Busan in Korea. Again, I tried live surgery. Here is a patient who missed the maxillary posterior region. Okay, this is tracing of a panoramic view, right and left side. In close-up, right side sinus is healthy, but remaining bone height is 3 to 7 millimeter, and sinus septum exists. Left premolar site, we can see narrow ridge. It looks quite narrow. And left molar site, residual alveolar bone height looks 3 to 6 millimeter, but there is unknown sinus lesion, so I must open and identify the pathology. This is my treatment plan. First, I will try right CSBA using the casket on the high-density endoscopy. Second, I will perform lateral SBA using the lasket. Okay, I must check the pathology in the sinus. Okay, and I must do ridge split using the essay kit, and if necessary, I'll perform GBR at the left premolar region. Then I will place total 6 implants. Okay, with my colleague, ENT Dr. Kim, and my staff, I started live surgery. Okay, here, look at the videos. Upper is a ridge split on the essay kit, and left side, crestal sinus bone augmentation surgery using the casket, and the right side, lateral sinus surgery using the lasket. Okay. Okay. Every site there is a risk point. I must concentrate on surgery. Okay. During the ridge split, I used the microsaw carefully. Okay. On the left side, you can see the successful sinus membrane separation using the hydraulic lifting system. And the left, right video, we can see the mucus retention system in the sinus. Okay. So I must control the pathology of on left maxillary sinus. Okay. Carefully try the ridge split on upper video. Gently use the chisel and split the ridge. This video is also available in DentalBean website. Okay. I hurried up because I must do many things. It was my limit during the surgery. Okay. Please watch this video, full video, in DentalBean website. Here is the POP radiograph. We can see the nice implant installation with sinus surgeries and ridge split. Okay, 3 months later, I performed the second stage surgery. Okay, the ISQ value was not bad, and the bone was nicely regenerated. Okay, especially premolar site, I performed ridge split and successfully made bone like this. Okay. Then bridge was delivered to patient. This is 1 year and 5 months follow-up. Okay. And this is 3 years and 8 months follow-up. Okay, next, my contributions to sinus bone augmentation surgery. I devoted myself to educate sinus bone augmentation more than 15 years. In my memory, I operated more than 15 times sinus bone augmentation training course per year, and clarified the principle of sinus bone augmentation and introduced simple terminologies for sinus bone augmentation. I introduced and distributed hydral lifting system for CSBA surgery, simplified the CSBA surgery, and I optimized, standardized, and simplified the LSBA surgery, introduced CLSBA surgery. I summarized and clarified the diagnosis and the management of maxillary sinus pathologies, systemized and improved the method of managing maxillary sinus complications. Especially, I introduced CSI technique to manage sinusitis. Last, conceptualized the depth control during the second stage surgery. I will show some of this in following lecture. What is principle of sinus bone augmentation surgery? Okay. First, separate sinus membrane sufficiently to provide space, blood clot formation, and bone cell supply. This is most important during the sinus bone augmentation surgery. Okay. Second, keep the space to prevent re-pneumatization. Okay. It is simple, but you must memorize this. Okay. This is a very important principle of sinus bone augmentation surgery. 2017, I proposed a new terminology for sinus surgery. Because of current, the past terminology looks illogical, even ridiculous. Okay? The technique changed, the concept changed. We must use more logical terminologies. I proposed this terminology, sinus bone augmentation, SBA. And when we try crestally, it is CSBA. When we do lateral sinus surgery, it is LSBA. Sometimes we can do both, that is CLSBA. So using this terminology, we can simply describe method, tool, and material in your chart. Hydral lifting system. This is a really powerful tool to separate the membrane. I introduced this device without understanding the importance of hydral lifting. But after I experienced, I found that this is a game changer of sinus bone augmentation surgery. We can separate the membrane as we want. We can control membrane separation with a hydral amount of saline. Okay? It is very safe and controllable. Okay? Then I will show an example of CSB surgery using the hydral lifting system. Here is a 27 implant with a CSB surgery case. I performed the surgery, and my colleague, Dr. Kim, he is a prosthodontist, performed the restoration. The keyword of surgery is delayed implant surgery, CSBA surgery, Flapless surgery, no bone graft implant on 27. Okay. It was 51 years old female patient who planned to extract the 27. Okay. I didn't perform the immediate implant surgery. I just tried delayed implant surgery. After extraction, I just wait. Okay. This is 3 months and 2 weeks after the extraction. In panoramic radiography, the extraction site looks well healed, and I measured the remaining bone height. It was about 5 millimeters. Okay. Clinically, the ridge looks wide and broad, sufficient attached gingiva, so I can do flapless surgery. In CT view, remaining bone height looks about 5 mm, and the buccopalatal distance was 11.9 mm. Okay, not bad. My plan, I will perform left CSBA using the casket with the normal cell line, without graft, and I will place 4.5 by 10 mm implant at that site. It was my plan. Okay, it was flapless surgery. I didn't open the flap and use the casket. Okay, this is very fine crestal sinus surgery kit. I started with a 2.2 twist drill with a 6 mm stopper and gradually changed the diameter and the stoppers. Finally, I can pass the sinus floor with a 3.3 cast drill with 9 mm stopper. And then I separate the membrane using the hydraulic lifting system. Next, place the implant without graft. Okay. After control depths, I connected healing abutment. Okay. Depth controlled about 4 mm, and insertion torque was 20 Newton centimeter. I/S value 6370. Not bad. Okay, look at the video of this case. Okay, it was flapless surgery, so directly I started drilling. I don't do punch out, just do drill. Okay, it is direct drilling technique. Okay, I'm using 7 mm stopper with cast drill. Okay, it was not passed, then I will advance drill until it passed the floor. I'm checking with a 9 mm stopper. It is not passed yet. Then with a 3.3 cast drill, I advanced 1 mm further and then found it was passed. Valsalva's maneuver was done. It was not perforated. So I decided to separate membrane with a hydraulic lifting system. Okay, as you see, membrane separated very successfully without perforation. Look at the color change. This is a sign of successful membrane separation. Okay. Then I place the implant. Okay. As you see in this video, the procedure is very simple. Okay. I usually spend 3 to 5 minutes to place implant in with this tool. Okay. Now I have to control depth of implant. Watching the fixture drive. Please watch the laser marking system on fixture drive. The top laser marking is 5 mm. So usually I place about 4 mm. Okay. At the depth control, I will connect the healing abutment. Okay, I'm checking here I/S value 67, 70, not bad. I can do one stage surgery. Okay, so I connected the healing abutment and then finished the surgery. Okay, this is POP radiography. Okay, it was done very successfully, and my colleague Dr. Kim continued prosthetic procedure. 2 months and 2 weeks later, I/S value was checked 78. Good. So he took impression and fabricated restoration with a customized abutment with a full zirconia crown, and then it was delivered. Okay. So case finished like this. Okay. About 7 months and 3 weeks after delivering a final restoration, this is a follow-up. Okay, and this is a radiographic view. Look at the change of sinus flow. Okay, here this is original remaining bone, and 10 months after the operation, look at the new bone formation in the sinus. I didn't graft it. Okay, just with hydraulic lifting, we can make bone. The procedure of lateral sinus bone augmentation surgery is not simple. It is complex. From incision, window osteotomy, or membrane separation, drilling, fixed installation, bone graft, flap close, every step requires optimal instruments and final surgical technique. Okay? To do this well, you must optimize, standardize, and simplify every step. Okay? I hope to show you the most fine sinus bone augmentation surgery in the world. Okay? And one more, my contribution is introduction of CSI technique. Here is a case. Patient missed 26 and 27, and I performed the lateral sinus bone augmentation surgery with a graft material. Maybe it was my record of lateral sinus surgery. I spent only 10 minutes. Only 10 minutes. That time, I used allograft, okay, this graft material. During the bone grafting, there was an accident. My staff dropped the bone graft material during the unpacking. So I let her open the cap and pour the graft material on the bowl and used that graft material. Okay. After the surgery, 1 week later, 8 days later, patient complained of thick nasal discharge with halitosis. This means that patient experienced post-operative acute sinusitis. I think the reason was contamination of graft material. Anyway, what should you do? When we experience such an accident, it is really trouble. Okay, what should you do? Okay, many dentists embarrassed in such a situation. I have an idea to solve the problem very easily. Okay, this is a CSI technique, which is introduced by me. Okay, with a double needle, I can clean the sinus. Okay, like this. Okay, one side suction, one side irrigation, syringe. Okay, we circulate the saline or chlorhexidine inside the sinus and clean the sinus. Okay, I didn't open the flap. Without flap opening, through the window hole, I penetrated the needles and then cleaned the sinus. After this, what happened? Okay, look at the following sequence. Here I performed the lateral sinus surgery. Okay, that time, graft material positioned like this. Then 8 days later, patient experienced acute sinusitis. Then graft material swelled like this. Okay, I performed the CSI technique, and after CSI technique, 4 days after CSI technique, patient symptom subsided. Okay, then 6 months later and 7 months later, okay, you can see very stable bone condition. So case finished. Okay, now I want to introduce the anniversary case of 5,000 maxillary sinus surgery. It was also worked with Dr. Kim. I performed the surgery. He performed restorative procedures. Okay. Keyword of surgery is immediate implant surgery, early implant surgery, pathology in the sinus, CSBA surgery, LSBA surgery, early second stage surgery, depth control during immediate implant surgery, depth control during second stage surgery, implant on, here and there. Okay. It was 61 years old female patient who complained of the discomfort of chewing. Okay. He has many problems at posterior teeth. We tried step by step. Okay. First, we decided to perform implant on right mandible because of masticatory function must be rehabilitated soon. My first plan was extract 45 and 48 and place implant at right mandible. Okay, I will extract these teeth and then I'll place the 3 implants on the right mandible. Then patient can use right side. Left side, the periodontitis was very severe. Look at the gingival recession also. Bone is very poor condition. I must do delayed implant surgery at this site. So during the first surgery, I will just extract that teeth. Okay, mandibular implant surgery was done simply, and then I extracted the left second premolar and second molar. Just extracted. Okay, in such a situation, just simply extract without the graphic curette or no need socket preservation. I just let it heal. Okay, this is the result of mandibular implants. It was finished 3 months later. Then, 3 months after the extraction of left teeth, I tried lateral sinus surgery with implant. Look at the healing, not bad. In panoramic radiography, bone looks not sufficient here. Let's trace. This is the maxillary sinus and alveolar bone, but I cannot see the cortical bone at crest at that point. Here, this is the posterior, and number 27 site, I cannot see the demarcation between bone and soft tissue. It is not clear. And here is soft tissue coverage. Anyway, I will do lateral surgery, and I will place 3 implants at the site. In CT view, I found pathology in the sinus. Okay, here, look. 26, 27. 26 looks limited bone height about 2 millimeter, less than 2 millimeter. And 27, where bone height looks less than 1 millimeter and pathology in the sinus. What is the nature of this pathology? Okay, there are several possibilities. I have to rule out antral pseudocyst, rule out mucous retention cyst, and rule out membrane thickening. Okay, it is difficult to distinguish just with radiography, and there's no exact guideline for diagnosis and the management of sinus pathology. I prepared a lecture. Okay, this is preoperative diagnosis of sinus pathologies and their management and CSI technique for sinusitis. Okay, it is total 6 hours lecture. I'm planning webinar in this month, 13 and 20, but it's just in Korean version. If you request, I will plan and present with the English version. Okay, so my treatment plan was I will perform left lateral sinus bone augmentation surgery. I must manage sinus pathology and then plan the 3 implants. Okay, open the flap as a routine with a routine flap design. Expose the lateral sinus wall. It looks very thin, and the thickness looks not uniform. Anyway, design the window and detach the bone window. Look at the color of membrane. This abnormal condition. So I tried explorative aspiration to test the contents. Okay, there are several possibilities. Sometimes you cannot aspirate. Sometimes you can aspirate fluid or thick mucus. This time it was exudate. It is yellowish fluid. Maybe this is good news. Okay, it is the pathology means antral pseudocyst. It is easy to handle. I separate membrane and then prep the holes. Look at the remaining bone height. 26 2 millimeter, 27.5 millimeter only. Here I prepare the bone graft material. It is a xenograft. It's very nice material. Recently, I only use this one for sinus surgery because of the efficacy of new bone formation. The speed is very fast and very effective. Anyway, here after bone graft, 3 implants were placed. Okay. Well, because of two less remaining bone height, I cannot get a strong primary stability at 26 and 27. 5 Newton centimeter and ISQ value 37, 37, very weak. 3 Newton centimeter, 20, 22, very weak primary stability. So I must connect the cover screws at that site. Okay. Finish the graft, reposition the bone window, and approximated the flap like this. Look at the video of this. Okay. With the number 12 surgical blade, I made the posterior vertical lateral incision and the palatally placed the crestal incision. Okay. Touch the bone and move slowly. Next, with the number 15 blade, I made a vertical incision. Okay. After incision, I elevated the flap using P24G periosteal elevator. During the surgery, I'm using very simple instrument, but it is essential instrument. Minnesota retractor is my favorite instrument. Okay. Me and my staff, my assistant, hold Minnesota retractor during the surgery and use that fine periosteal elevator. Okay. Using these tools, I can make good surgical field and elevate flap very quickly and very cleanly. In my mind, I have image of sinus, and then I designed the window and scored the bone window using number 2 sized small round burr. The thickness of sinus wall looks heterogeneous, okay, different thickness, so I must control depth of osteotomy and carefully score the windows. Do not try to infracture the window during lateral surgery. Better to wall up the window. That's more convenient and useful. Okay, almost done. Then up-fracture the window. Simply up-fracture and keep this window inside the normal cell line. The color looks yellowish, opaque yellowish. This means that it is abnormal condition. I'm trying to aspiration. Okay, it was yellowish fluid. Okay, it was a yellowish fluid. This means that the pathology in the sinus was antral pseudocyst. Don't worry about antral pseudocyst. Just identify and then continue operation. I'm separating sinus membrane using my favorite sinus membrane elevator. Okay, it was invented by myself, and only a single instrument I can finish every membrane separation. Okay, from distal, floor, medial, and the medial. Okay. Membrane separation is key of sinus bone formation, so you must separate membrane wide and sufficiently. After membrane separation, carefully mark the entry point, number 5, about 5 mm away from number 4. Okay, it looks a little bit narrow, so I must move the 2 palatally. And then about 9 mm distally, I marked number 6 implant position. Then about 10 mm away, that's the second molar position. Okay. Prep the osteotomy with drill. Keep in mind the path of implant. You must mimic the natural tooth root axis. In this case, I cannot keep the path well because of interference of anterior tooth. Okay, I'm checking position and path with the parallel pins. Okay, position of implant is very important. You must carefully mark and select the implant position. It should be center of final restoration. I'm checking the penetration of floor. I'm using drill extension to elongate the drill to avoid the interference, okay, and maintain the path a little bit medially. Final drill was used. And number 6 and 7, bone height was very limited. I controlled the drill depths carefully, and it was under preparation to get stability. Here I grafting xenograft. Okay. Maybe syringe type is more convenient, but this graft multi-bottle type, I must use bone carrier. Okay. Bone graft itself is not so important in reality. Even it is not necessary during the sinus surgery, especially when patient has narrow sinus, no need bone graft. Okay. In wide sinus, we must graft material to support the membrane, to keep the space. Okay. Here I place the 3 implants, 4 by 10, 4.5 by 10 at molar site. Okay. Although bone height was 2 millimeter and 0.5 millimeter, I like to place implant simultaneously always. I know the disadvantage of simultaneous implant installation, but there are many advantages of simultaneous implant installation. So I like to place implant simultaneously almost always, like this. Be careful not to drop implant inside of the sinus. Okay, disconnect mount and then control depths. One more thing is that please use implant with a mount. Without mount, we cannot control path of implant. The first implant looks strong enough. However, second implant looks weak. And the last implant very weak. It spins even with a free hand. I check the ISQ value. Okay, it's weak at the last implant. So I decide to connect cover screw at molar implant. And connect the healing abutment at second premolar site. Carefully connect the cover screw, not to dislocate implant into the sinus. Okay, I must be very careful. And then, okay, finish grafting. Okay, it is just loose grafting. Do not pack graft material. Just fill the space. Okay, after graft, some dentists like to cover that area with a collagen membrane, but I don't use collagen membrane. It is not necessary. Instead, I will finish like this. Not yet. Here. Finish the grafting. It looks sufficient. And then look, reposition the bone window. That's enough. No need to cover the site with the collagen membrane. And then approximate flap. Okay, simply approximate flap. I like to use 40 nylon. Okay, let's speed up. Here, with interrupted suture or cross-material suture, I continue the flap approximation. Okay, here I like to use cross-material suture here. To speed up, I use the cross-material suture at the site. And let your assistant hold the Minnesota retractor during the suturing for a better surgical site. Okay, this is also cross-material suture. Okay, let's finish here. This is POP radiography. As I planned, I can place the 3 implants. Okay, 2 months and 2 weeks after operation, I performed the second stage surgery. Although it looks too early, I have many good experience after using that graft material. I tried early second stage surgery. I-sq value increased to 66 and 59 to 60. Okay, it was originally very weak, but it increased like that. Well, I found another problem during the second stage surgery. It was insufficient depth of 26 implant. Generally speaking, I can say that depth of implant is very important, and you must place implant sufficiently deep. How much? Okay, about 4 mm from the gingival top. So this case, it is insufficient. I decided to control depth of implant. It was just 1.5 mm. So I turned the implant and controlled the depth to 4 mm. Okay. Then I-sq value decreased again. Okay. But don't worry about this. You can wait. Look at the second stage surgery. Usually, I don't open flap during the second stage surgery in such a types of implant, internal bone level implant, with a high speed around the burr. Okay, penetrate the tissue, gingival, and then identify the cover screw. Then disconnect cover screw like this. It is very simple second stage surgery. Check I-sq value 60, not bad. Okay, and then connect the healing abutment. Usually I connect 6 or 5. This means that diameter 6 mm, gingival height 5 mm healing abutment. But it exposed too much. It exposed more than 3 mm. This means that depth of implant looks just less than 2 mm. Insufficient. Okay, last implant, detected cover screw. I'm checking center of hole and move the position. And then connect the hex drive to disconnect cover screw. After removal of cover screw, I can check ISQ value. Okay. When it is difficult to remove cover screw, use that instrument. It is hemostat. With a tissue forceps, very difficult to remove, but with a hemostat, you can pull out with a strong force. Checking ISQ value, and then corrected the healing abutment. Generally, I do flapless second stage surgery. Okay, and look at the before and after second stage surgery. Look at the depth control. Originally, it looks like this. Because of too less bone height, I cannot place implant sufficiently during the first stage surgery. Gingival thickness was thin, so that's the problem. Okay, so I decided to push in the implant during the second stage surgery like this. Okay, we made the bone, although it is just 2 months and 2 weeks later, so it is not strong. But I carefully control the depths. If I wait more than 5 months, still I can get enough stability. But that time, it was weak. Okay. Another 2 months after the depth control, what happened? Look at the ISQ value. Okay. It reached to 70-70. And the last implant, 75-75. Not bad. Okay. And in this chart, we can see that the ISQ value change. Okay, 25 was strong enough originally, and 26 it was very weak. Also 27 very weak, but 2 months and 2 weeks later, I can get moderate primary stability at moderate ISQ value, and 26 was pushed in, so it decreased 30 to 37, 47. But 2 months later, what happened? You can see it increased to 70. And a total 5 months after the operation, ISQ value exceeds 75. So I can take impression. Okay? Dr. Kim took impression with digital scanning, and this is final restoration, customized abutment with a full zirconia crown. He delivered the restoration like this. Okay, it looks good, margin, and well done. Then on the right side, the patient also felt discomfort. She wants to do implant at that site also. Okay, this is the preoperative CT view. Okay, number 16 and 17, we can see limited bone height after extraction, but I can do immediate implant surgery during after extraction here. Okay, I extracted the premolar and simply placed the implanter. But maybe it was my mistake. I tried the flapless surgery at number 15, but it was a narrow ridge. I found that ridge was not sufficient. I decided to open and found a mistake in the position. I must move the position to lingually, palatally, and then pass the sinus floor, separate membrane, then place the implant. One more implant here. And the molar teeth were extracted. And again, I used the crystal sinus kit. And after pass floor, separate membrane, place the implant, and repeated. Okay, like this. Last implant site, same procedure was done. And total 4 implants were well placed. Okay, well, look at the ISQ value. Every implant has nice primary stability and strong ISQ value. So I can finish the surgery with 1-stage surgery. Healing abutments were corrected like this. Okay, simply approximate the flap. This is a POP radiography. I found incomplete sealing of healing abutment, so changed to longer healing abutment, like this. Okay, look at this video very briefly. I'm trying to extract the teeth. Okay. Extract teeth, and then premolar was also extracted. It's immediate implant surgery, not so difficult. Okay. Bone height was not bad at that site. Simply finish the drilling. Okay. Slightly palatally moved, and then finish the drilling. And Flapless surgery was tried at second premolar, but it was not good because ridge was narrow. During the drilling, I found something wrong, so I decided to open flap. Okay, better to open flap in such a situation. During the checking, I found it penetrated the buccal wall, so I decided to open flap at that site here. I must move palatally. Okay, correct position and use the cast drill. Bone height was not sufficient at that site, so it was passed. Here I seal the hole, but cannot. What should you do? I have a technique when I cannot seal the hole well. It skipped. I shoot the cell line to separate membrane at that situation and place the implant. Okay. After placing implant, I extracted the molar teeth. Okay. And then again I tried the crestal sinus bone augmentation surgery. Okay. Mark the entry point at center, and then gradually advance the drill. Gradually advance the drill to penetrate sinus floor. We don't know exact height of the bone. You must do trial and errors. Okay. Now it passed, so I can do hydrolifting to separate membrane and then place the implant. I didn't graft it in this case also, because the remaining bone height was not bad. Okay. Here, place 3 implant. Okay, last implant, same situation. I will pass the floor with a crestal sinus surgery tool. Okay, I will try advance drill until it passes the floor. After pass, separate membrane, place implant. That's all. Very simple. Usually, my surgery is very simple and speedy. I don't do graft actively. I don't use membrane actively. If it is necessary, I will do. But when it is not necessary, I don't do that. In such a situation, it is not necessary. Okay, enlarge the hole, and again I try the hydrolifting. Okay, it looks successful. Then place the last implant. Okay. Mount is indicator of implant position and pass. Okay, please use implant with mount. That's the best way to place implant well. Control depth. Carefully check ISQ value, and then connect the healing abutment. Every implant has strong primary stability, so that's why I did a simple healing abutment connection and approximated the flap. This is POP, radiography, well-positioned implant and good pass. Here, CT view. This is CT view. Implant positioned at center of the ridge with a nice hydrolifting. Okay, 2 months and 2 weeks after the placing implant, it was good condition. ISQ value looks good, so Dr. Kim continued restorative process. Okay, took impression and fabricated final restoration. Okay. Then it was delivered in the patient mouth like this. Okay, it is full zirconia crowns. Okay, here, nice fitting, of margins. Okay, follow up, looks good condition, and patient want to change the another restoration because she satisfied the other restorations. Okay, look at CT view here. Well, on the right side, it is just 5 months after placing implant, so there's no definite cortical layer at sinus floor, but I'm sure that newborn will form, and we expect a nice result. Okay. Here is panoramic radiography. Follow up 5 months after the delivering final restoration. Lower 1 year and 3 months. Okay. Left side 9 months and 1 week after delivering the final restoration. It looks very stable condition. So this is the before and after surgery. Okay. It changed much. Okay, not only functionally but also aesthetically, it improved much. So patient satisfied 100%. Epilogue. To improve our practice, knowledge, experiences, insight, and challenges are necessary. Our practice will be improved by taking knowledges and many experiences. Sometimes smart insight or brave challenge will make us jump to the next level. Okay? Repeating this sequence, you will advance. Okay? I spent about 24 years to reach this level. Nowadays, I like to listen other speakers' lecture. Sometimes I can take some useful messages from them, but sometimes I feel sorry because some speakers repeat all the process just based on their knowledge and experiences. Here I prepared an express cable car for you, okay, to reach to my level. At DentalBean website, I present a full lecture about sinus bone augmentation surgery. These lectures are essence of my knowledge and the concept about sinus surgery from A to G. Okay? This lecture is exact cable car which guide you to my level very quickly. My lecture will be helpful not only for beginners but also for experienced dentists, especially to speakers. Okay? Last year, I must cancel all my schedule at overseas. Okay? I wish the COVID-19 ends soon and hope to meet you face to face in my offline training course. Until then, be careful and be safe. Okay, everyone, Happy New Year and thank you for listening.